Hi, I'm Valerie Burns. I'm a licensed professional counselor and clinical substance abuse counselor here in Madison, Wisconsin. One of the most common reasons why behavioral health care providers get called in to do interventions or talk to clients in integrated care settings, such as hospitals, jails, primary care settings, is because clients present as angry, irritable, anxious, restless, dysphoric, and it's usually if we do some digging following some substance abuse. So, we always hear about how clients are, we use the word intoxicated, right? They're disinhibited while intoxicated. But what we don't often hear is that clients are actually disinhibited even while they're withdrawing from substances. So I'm going to challenge you to start looking at clients who are actively withdrawing from a substance. This is whether it's a weekend of binging, a night of drinking with friends, maybe following detox. I want you to start conceptualizing clients who are withdrawing from a substance also as disinhibited. The reason why is because the chemicals in their brain are still kind of recalibrating following the substance use. And what we oftentimes will see is that clients are irritable, anxious, dysphoric, and restless. And I'll challenge you too, think back to the last time if you've had a few glasses of wine or went out on the town with friends. I'll bet that following day you felt a little sluggish, maybe a little irritable or anxious, maybe even tearful. And sometimes it lasts up to 2 days, depending on your metabolism and age. So, we're going to kind of look at the processes involved with common withdrawal presentations. We're going to talk about alcohol use and withdrawal, and then also opioid use and withdrawal. And what we can look at, what we can kind of broadly say is that there is a what goes up must come down type of effect that happens with withdrawal. So whereas with alcohol, alcohol creates this kind of sleepy, relaxed kind of state. People are able to relax, kind of get silly with their friends. What we're doing in our brain, if you picture our brain as the engine in our bodies and selves, which is the car, when we drink, we're kind of pressing the brake pedal a little bit, just kind of taking the edge off. And so you can imagine that when we're drinking, that brake pedal is going on, right? Well, our brains are actually really, really good at compensating for these effects of substances to keep us alive. I mean, in fact, we hear all the time about how people who were completely intoxicated and blacked out did all of these things, right? Well, our brain does a really good job of keeping us alive despite crazy circumstances. And one of the reasons why is that there's a compensatory effect that happens in the brain. So with alcohol, what ends up happening is that our glutamate chemical, glutamate is an excitatory chemical. You can kind of think of it as the gasoline in the brain, the engine. And alcohol actually inhibits our ability to sense glutamate, right? So what you can think of here is that this inhibition of glutamate is the gas pedal, right? So our brains can't sense that gasoline in our brain. So while we think that when we drink, it feels like we're putting on the brake pedal, what's actually happening is that it's just masking this gas in our brains. So what does our brain do to compensate for that we need gas in our brains to complete different processes to keep us safe and all these things. And so what our brain does is it actually overproduces glutamate in our brains. It actually presses down on the gas pedal, but while we're actively inhibited, actively intoxicated, we actually can't sense that. And so what ends up happening is that as the effects of alcohol wear off, we end up getting this elevated level of gasoline in our brains unmasked. So if you think back to the last time you drank, if you have had a couple of beers one night or a few glasses of wine, think about the next morning. Did you get a good night's sleep? Did you sleep in like you expected to? Oh, it's fine. I don't have to go to work the next morning. I'll just sleep it off. What usually ends up happening is we end up waking up way earlier than we expected to go to the bathroom, get a drink of water, and then oftentimes we don't sleep very well. The reason for this is because we've got a lot of gas in our tanks, in our engines, which is unmasked after that amount of alcohol wears off. So anyway, what we end up seeing in clients who are withdrawing is that they have this elevated level of gas in their tank. And then what ends up happening is that they're still, despite having this extra gas in their tank, they're still a little bit groggy. And so oftentimes the patients that we see presenting in clinics who maybe are alcoholics and they're withdrawing are highly irritable. So their amygdala is really fired up with excitatory chemicals, yet their frontal lobes, which are the smart, evolved part of the brain, the brake pedal in the brain, those are still not quite on board yet. So if you're working in a hospital and you're working with a client who is actively coming out of a significant withdrawal period, one thing that you can really expect to see is someone who's really, really behaviorally out of control. So you're kind of going to conceptualize them like a runaway car, right? Way too much gas, not enough brakes. And so hang on to that. We'll talk a little bit more about behaviorally what to do in that case. When we're looking at opioids, we're talking a little bit less about the glutamate chemical, the excitatory chemical, and then the GABA. Gabapentin is usually a medication used to treat withdrawal. So it has a soothing kind of brakes effect. So that's what we see with alcohol, GABA versus glutamate. And with opioids, it's typically an endorphins versus adrenaline issue. So opioids imitate endorphins, and endorphins are really important stress modulators in our body. Endorphins and opioids both decrease our response to adrenaline. So for someone who doesn't take opioids, usually our endorphins will help to dampen the response of adrenaline. For example, if you get really scared, if you have a lot going on, you'll experience like this kind of flood of adrenaline, and the thing that helps to take the edge off of that is endorphins in our body. So when people who are really anxious, a lot of times people who have high anxiety, they tend to be drawn towards opioids. When people take opioids, it really kind of helps them to feel like, again, like alcohol, right? Taking the edge off, kind of a soothing feeling. They get really relaxed, numb, and sleepy when they take too much opioid. And then what happens in the body is that it compensates, the body, the brain, compensates for the opioid use by increasing adrenaline levels, right? And so what ends up happening when an opioid is taken away, people are withdrawing from it, or it's blocked, like in the case of Narcan, these elevated adrenaline levels are unmasked, and that manifests as irritability, anxiety, restlessness. And then you also see sometimes like the sweating and things like that people talk about with opioid withdrawal. So similarly to the runaway car analogy that we talked about with alcohol, individuals withdrawing from opioids also have way too much gasoline in their car's engine and not enough brakes. So it's really like someone who's just coming out of a really deep sleep in both cases. If you can imagine just being woken up after, being in a very deep sleep, it takes a little bit to kind of come online, right? Like maybe you wake up with a big alarm system going off and like you're awake, your body's kind of going through the motions that it knows it needs to do, but it takes a little while for your smart brain to come online, right? All right. So cravings usually happen with opioids and alcohol because people learn to associate these feelings of being soothed with those elevated levels of anxiety and anger. So I know when I'm anxious, I'm going to take some opioid, or I know when I'm anxious, I can just drink a little bit to take the edge off. And so it becomes kind of an association. With alcohol, there's also some sugar things involved, which is, another reason why people who stop drinking oftentimes end up compensating with sugar. All right. So some skills for behavioral health care providers. So our culture has this social contract, right? We have a lot of really unspoken rules and expectations in our culture. And so one of them is that we can expect that when we help someone, that they're going to be gracious and they're going to be thankful. And so a lot of seasoned nurses know that this is maybe not the case, but our culture's social contract really kind of dictates that we can expect patients to be thankful and gracious for our services. When someone helps or takes care of you, you give gratitude in return. So what happens when this social contract is broken, right? And it oftentimes is broken a lot when we have people in active withdrawal in hospitals, in primary care settings, and they're just kind of like this erratic runaway car of like a lot of big emotions, but just like not a whole lot of control. Oftentimes our instinct is to really stand up for ourselves, set really, really rigid boundaries, or sometimes we try to teach our patients by shaming them and teaching them, right, that their behavior is not okay, or we just discontinue their help. This is honestly really counterproductive to an intoxicated patient because as we talked about before, the frontal lobes of a patient are really unable to process this social behavior during withdrawal. Too much gas in the amygdala, the frontal lobes really become disinhibited. They're not able to really have a lot of future orientation or process social behavior, which is, kind of a higher construct. And so instead, what ends up happening with the shaming behavior, discontinuing help, setting firm boundaries, is that people end up going into fight or flight mode. So oftentimes what we see is they end up fighting, arguing, asking to speak to the manager, or eventually they just leave. And then withdrawal individuals, just remember, they are not capable of mental flexibility. So when working with someone, again, remind yourself this person is still disinhibited, okay? So the best thing to do in these cases is to stay calm, distract the patient, and also redirect them. And I like to use the 5 C's. I'm going to go through them, and they are in your handout. The 5 C's are clear, calm, consistent, compassionate, and curious. So just remember, it's a bunch of C words having to do with behavioral health. Stay clear. What do you know as a mental health practitioner now about how alcohol and opiate withdrawal affect the patient? All right, and affect the brain, affect social behavior. And then next, be calm. Stay calm through all of this. I know underneath, like inside, you're probably feeling really scared. I mean, the person is probably really confrontational, but stay calm as much as you can. Keep a neutral face. And I like to use, someone once told me, be like kelp in an ocean. They also say like, be like a duck, right? Like calm on the top, but paddling underneath. But think about kelp. It grows in like the craziest parts of the ocean. It's like 100 feet tall. It's grounded, it's rooted in the sand, and then the top part is just tumbling around with the current, right? So it's rooted to the ground. Stay rooted to the ground in what you know in your expertise as a mental health clinician, but also be kind of flexible in going with the flow. So not super, firm walls, right? But boundaries that are a little bit more flexible. Stay consistent though. Everybody should have each other's backs and speak the same language. When you're working on a team, when you're working in a healthcare team that's working with individuals like this, it can be really, really difficult. Oftentimes we want to be people pleasers. We really want to help the client, but we do also have to know what our limitations are, and we really have to stay consistent in having each other's backs and knowing what the boundaries are. Practice self-compassion. Compassion is the next one. Compassion, to be empathetic of yourself, compassionate of yourself, and realize that this doesn't necessarily mean, having compassion doesn't mean that you are going to fix this person or that you're going to fix anyone. For example, if a patient's really screaming at you, you can say something like, I totally hear you. I know and I believe that you're trying to tell me something right now, and it's really important, and I really, really understand, but I just can't process what I'm being yelled at. And so I'm going to try to just catch my breath right now. I'm going to slow down for a moment so I can think, and I'll be back in an hour, and then maybe we can try again. right? And you're just going to leave and give them space, take your space, collect yourself. Again, be clear, calm, consistent, compassionate. And the last one is to stay curious, okay? We've talked about, a little bit ago, we talked about how people tend to use alcohol and opiates to kind of put the brakes on, maybe self-medicate. We hear that a lot in substance use treatment. Stay curious about, why is this person drinking? Why is this person, right? Like, what's going on? What's actually going on with this person? They are not themselves right now. So what is themselves? How do we help them get there? Curiosity is often so much shut down by judgment, assumption, fear, and uncertainty. So really take the time to slow down. Okay, hold the other person in mind and your own self, right? Knowing your triggers. Most individuals with AODA issues, alcohol and other drug AODA issues, have serious trauma histories, whether that's big T trauma, like this thing happened to me, or most commonly is little t traumas, right? Cumulative traumas that happen in relational or social contexts. And so we don't know what that other person's experience is. So just we can choose to shut down and just like assume a pathological stance, shut down and not care, or we can just kind of assume a stance of authentic curiosity using our trauma-informed lens, and do what we do as therapists. So thanks for listening. I hope that this was helpful.